Good. So are you ready? Okay. So, okay. Welcome back to the BioMedVis Spring School. And now we are really running to the end. This is our last session. We still have two exciting talks, so please stay with us until the end of the program. So our first speaker in this session will be Anamaria Crisan. She is a multidisciplinary researcher at Tableau Research. She integrated techniques and methods from applied statistics, machine learning, human-computer interaction, and data visualization. Her research focused on interaction of data science and data visualization, having a focus on how humans can collaboratively work together with AI systems. She completed her PhD at the University of British Columbia. She was also a research scientist at British Columbia Center for Disease Control and Decipher Bioscience. Anamaria will talk about BioVis in clinical and public health practice. Let us welcome Anamaria, and the floor is yours.
Thanks very much. Thanks for having me. It is about 8:45 in the morning in Seattle. I hope that you are having a very lovely day wherever you are in the world. So today I'm going to be talking about whether a picture can save 1,000 lives. And I want to talk about this in the context of BioVis as it's been applied in clinical and public health practice. And I'll talk a little bit about my own work, but I'm going to be framing the discussion today in some 4 examples that I think show how BioVis can have a very large impact in both clinical medicine and public health. And I also want to talk a little bit about what the differences are between clinical medicine and public health and where their overlaps are too. So first, I want to tell you a little bit about how I got where I am and where this talk and the examples that I pick are coming from. So today I am a senior research scientist at Tableau. I have been there for a little over 1.5 years. Prior to Tableau, I had spent time in various positions, always doing research within academia, within government, and also within industry. So my academic work has always been in computer science focused on biomedical applications. Shortly after my Master's of Science, which was in a cancer research lab, I worked at a startup called GenomeDX. And there we were actually applying machine learning to analyze cancer genomes and try to understand which patients were at risk of developing metastatic cancer. A lot of my interests in visualization and motivation came from those experiences where not only was I trying to make sure that the genomic classifier we were developing was safe and accurate, but also that it was understandable by patients and doctors that would actually have to apply this to their treatment. And for context, the thing we built there did actually get used in clinical practice. It's actually covered by insurance in the US and I think even in Europe now. Building on from what I learned in the cancer space, I went and worked at the British Columbia Center for Disease Control. This was the transition between working in clinical medicine to public health. And here I was working with public health experts to understand emerging diseases, both in our neighborhoods and around the world. So I was with them as the Ebola outbreak broke out, as well as Zika, but also as we had various problems with measles in the community around us. Those experiences in industry and academia led me to my PhD in data visualization, where I was looking at visualizing heterogeneous data in genomic epidemiology. And the central tension there was there's a lot of data, it needs to be integrated, and there's a lot of different types for people to make sense of. And I further generalized that working at Tableau, where I was looking at the coupling of data science and machine learning methods that I had used throughout my career with data visualization. And Tableau, if you don't know, is fundamentally a data visualization product. So this is where the total of my experience has been. If you do have questions at the end of the talk about what it's like to work in these different sectors and to be a researcher in these different sectors, I'm happy to answer those as well. So over the course of my career, prior to joining Tableau, I did a lot of stuff in cancer clinical genomics, as well as public health genomic epidemiology. And my work in the cancer space varied from setting up data pipelines, building new machine learning methods, to actually discovering and visualizing signals of cancer in patients and in populations. In the public health space, some of the work that I did was much more focused on the populations themselves of people and looking more at the dynamics of outbreaks and diseases as they spread. Very, very much like our current ecosystem and current environment that we're all dealing with right now. And so for these different areas, the kinds of visualizations that I used and focused on did actually change. One thing that was similar was the types of data that we were using. So in the epidemiological space, we talk about the data that we collect from people. That's stuff like outcomes in treatments. If you are looking at a human in a clinical medicine context, you're also taking a look at their genome. If you're thinking about public health context as well, you're looking at the genome of their microbe. And another little interesting bit of personal data that I started working with more in the public health space was also contact network data. And so this is basically the social network of who infected whom. And this is often painstakingly constructed through interviewing actual humans, but could also be supported by genomic reconstruction of infected individuals as well. In addition to this person data to try to figure out, what was going on, we had place data. Again, this tended to be much more common for public health applications. And then, of course, we had all of this data over time. So depending on where you're coming from, this is either a curse or an abundance of data. Generally, I found both clinical medicine and public health had a lot of data, especially in clinical medicine, we had a lot of data on one person over time. Whereas in public health, we had a lot of different kinds of data on a population spread out over time. The other thing that was really interesting and challenging, both about working in clinical medicine and public health, was the stakeholders that were involved and the kinds of people that had to make sense of this data or even digest the data visualizations that I was producing. And so once again, we have either an abundance or a curse of stakeholders, depending on how you think about it. Usually in clinical medicine, if you're a researcher working in those settings, what you're mainly thinking of is the clinician, which is the person doing the treatment or the intervention, as well as the patient. And so that relationship can be quite small. Whereas when we're thinking of something like in public health, the kinds of people that had to digest and make sense of the data were the clinicians and affected individuals as well. But it also was individuals in the community, politicians trying to enact changes. There were also different hierarchies and levels of administration within a healthcare system that we had to reach out to. So while there was this idea that, okay, we have more people, they're multidisciplinary teams, so they're going to work together to make more informed decision-making, often what was also the case was you had to work with a lot of different people that had different needs of the data, different understandings of the data, and that needed the messages to be communicated to them in different ways. So from that sort of high-level view, even though there's a lot of similarities between clinical medicine and public health, the biggest difference that people tend to hone in on is that clinical medicine is focusing on the relationship between a single provider, which is the clinician, and the patient, and understanding that patient's individual context. Whereas public health has largely been focusing on the individual in context of their community and more of like the community and the population health. They share a lot of similar data, they share a lot of similar stakeholders, but their goals, their aims, and their means are fundamentally different. And so to give you a sense of what visualization might look like in the context of clinical medicine and public health, I'll start with some examples from my own work, and then I'll bring into 4 examples of work that other people have done that I think tell really nice and compelling stories. So this was actually one of my first kind of forays into data visualization. What you're looking at here is actually a cancer genome. And this was back in 2012. So this is when we first started getting technology that was able to actually sequence cancers at scale. And what we're taking a look at here is we're using different technologies to see whether we can pick up the signal of this chromosomal abnormality in a single patient with breast cancer. And so what we're looking at here is the intensity of the signal, as well as how we're taking a look at the genotype. And what we have at one part of the chromosome is in blue, just everything being pretty much normal. And then in red, seeing this big anomaly and shift, which we actually can capture across multiple technologies. So at this stage in the research process, it was both understanding that the signal could be tracked across technologies, but also that we could detect it and verify it in the lab. This was different than work that I did later on, where we were actually trying to take a look at a tuberculosis outbreak and understand whether we needed to change policies in a shelter for unhoused individuals. So here we were looking at how TB was actually spread based upon the movement of individuals that stayed within a common shelter environment. And so we had the room, we actually had the genomes of the patients and their infection status over time, and we were trying to trace and follow them through the room to see if they infected their neighbors while they were sleeping there. What's interesting over my career is that now that we can do things like single cell genomics, we're actually able to do some things in cancer medicine, in cancer clinical medicine that we couldn't do before, that starts to look a lot like epidemiology, where we look at the evolution and the traces of cancer within an individual as well, looking at things even like phylogenetic trees, which wasn't happening at the start of my career. But of course, the point of my presentation was actually whether a visualization can be used to save lives. And so here I want to bring out 4 examples, 2 from clinical medicine and 2 from public health, that I think paint a compelling picture of how data visualization, when well used, can be used to save lives. And so in clinical medicine, I'll talk about breast cancer therapy choices as well as surgical planning. And in public health, I'm going to talk about some of the recent stuff of COVID transmission and actually reporting and sharing information about COVID-19. So let's start with the clinical medicine case of breast cancer therapy. So this was true as well when I was working a lot in the cancer space. Whenever we do an analysis for somebody of their genomics, even if it comes at the end of a very fancy and complex machine learning pipeline, at the end of the day, somebody has to make a choice about what they're going to do with the information in front of them. And they're often given just a single number to do so. For example, your risk of actually having metastatic disease in the next 5 years is 50% or 90% or 10%. It's actually very hard for patients to make sense of that information. And so there's been a lot of work in the risk communication space around visualizing that data. Now, this was an interesting study that tried to look at different visual alternatives of showing this information to individuals that could select multiple options for breast cancer therapy. So they had the choice of looking at additional therapies, either adding chemotherapy, hormonal therapy, or both. They had the choice of adding no additional therapies. And then what the visualization initially showed, which was this bar graph, was the probability of different outcomes. What would you survive if you did nothing? How much more likely are you to survive if you were to add hormonal therapy or chemotherapy or both? And mind you, adding treatment is not neutral. There's a really big effect of having to undergo harsh treatment. So this was an initial visualization, a bar chart that actually had the color-coded outcomes, green being general survival, yellow being the benefits of therapy, red being just you're going to die of cancer no matter what, and then purple or blue being death from other causes. Now, in the alternatives that they explored, they actually took a look at first just doing the same color coding scheme, but looking at an icon array. And here they're giving patients the alternatives between hormonal therapy as well as hormonal and chemotherapy. And then another alternative was just to simplify them, just to show the added benefit of therapy, which is the 2 yellow bars there, without actually having any additional outcomes. This is a great example of how visualization choices really matter. And so when they actually did this in a randomized trial with 2,000 patients or 2,000 women that were of age to have breast cancer, they may or may not have had it at the time, people overwhelmingly preferred alternative 2. And they did this because they felt that it both helped them understand their risk a lot better. They understood the information more effectively, and they could make a more informed choice in their care. So they actually went and actually built a gallery around this. So you can actually take a look at communicating risk based upon what your different goals are and what you want the patients to do. And they've actually done a bunch of randomized trials on visualizations to demonstrate their effectiveness across multiple visual alternatives. And now their findings is actually not that surprising. In fact, medical risk communication has shown time and time again that numbers are inequitable. In fact, they've done some studies here. This is one where they were comparing the use of relative risk versus absolute risk, and then with an icon array and without an icon array, or with like a visualization without a visualization. And what their study found was both in older adults as well as students, individuals with low numeracy and high numeracy, having a visualization helped people understand the information that they were presented. It helped them understand what choices and options and treatments were better for them. And this is a result that's actually been replicated in a number of studies. So if literacy is the ability to reason with words and letters, numeracy is the ability to reason with numbers. And in fact, the vast majority of the population has low numeracy. Although there's a correlation between numeracy and the ability to read a graph, a well-designed graph makes a huge difference in improving comprehension across the population. So that was one outcome. This is an outcome of risk communication, but there are other ways that we apply biomedical visualization. Like I showed you earlier, there's a lot of different kinds of data. So here's one with surgical planning. You may have seen this study before. It's actually by Michelle Borkin. It's a really lovely example of how challenging the norm with visualization can actually improve things. And so in this particular study, Michelle was working with cardiologists at Harvard, and they actually already had a way of visualizing heart artery data for surgical planning. And that was this 3D visualization with this rainbow or the jet color scheme. And so somebody who wanted to actually plan a surgery and wanted to look at the patient's results would more or less have to rotate this and look at the colors to try to figure out where there were blockages in the arteries and where they may want to basically intervene with the surgery. And so if done biz stuff, there's issues with the 3D, with cognitive load, there's issues with the jet color palette in terms of misinterpretation. And so Michelle's actually set out to redesign this. And so they did this in a pretty interesting way. They first compared 3D versus 2D. So the color scheme was held constant, and they just sort of changed the visual representation. And the 2D layout here is actually the hierarchy is representative of the arteries of the heart and their hierarchy. And then she also worked on changing the color scale from jet to a divergent color scale, from black to red. And here what we're doing, I think she was showing like the pressure in the heart, and the more pressure there was, the more likely there was to be a blockage. And so they actually did an experiment, again, a trial where they compared these two different conditions. And what they had is a gold standard data set that was established by senior cardiologists. And they had trained medical residents then take a look and try to actually detect blockages using the different types of visualizations. And the results were actually pretty stunning. So when they compared the original, which was the 3D with the jet color scale, the accuracy they had on that was about 39%, which meant that they were actually missing a lot of blockages. Whereas when they looked at the alternative of the changed color scale with the 2D, the accuracy went up to 91%, which meant that they actually were finding more blockages. So it's my understanding from Michelle that this actually, this tool is used in clinical practice at Harvard, that it actually changed the way that they do practice there, because they could see through the experimental results that it was so much better to look at it this other way. And there's also reasons why this could be. For example, rotating something in your head and keeping track of what you actually found is a cognitively taxing task. There's also issues with the jet color scale that's not intuitive to resolve. The 2D solves some of these problems by basically making things kind of flat, and also so you can see everything, no need for rotation, and the color scale works a bit better as well. So those are two examples from clinical medicine. As you can see here, what we're doing is we're focusing again on the individual, the person's heart, right? Or the person's individual clinical risk. But now we're going to take a look at something that's a bit bigger. We're going to take a look at the level of the population. This is actually looking at COVID transmissions. And so here I want to talk about actually a series of tweets that happened in February 2020 February 2019, 2020. And these were like important tweets for me because that's when I realized like we were in trouble. So Trevor Bradford is actually a researcher here at the Hutch while I was doing my PhD. I hung out with his team in his lab. And they were running a Seattle flu study. They were a lab that was trying to study how the flu transmits in Seattle. They also did a lot of really nice work of actually helping out the CDC understand the transmission of flu at the US level as well. And so as in February 2019, February 2020, this was before the pandemic really broke out, but was already like spreading in Wuhan, and China at that point had lockdown. And so what they were doing is they had a study looking at the flu and how it was transmitting, and they decided to actually just modify some aspects of that study because the SARS-CoV-2 genome had actually been published online. And they were like, let's see if we can detect it. And they did. This was before there was any sort of testing that we had in place. I think at the time there was one case reported in Kirkland, which is across the water from me. So this was also relevant because Seattle was ground zero for the COVID outbreak in the US. So they were actually able to find it. Now they also had a tool that they had been developing for quite some time called Next Strain. And so what's also interesting about the whole story of this is data becoming available online, data analysis pipelines getting ready to go, and then the output visualization at the end that helped contextualize things for everybody. And so here they were actually taking a look at the versions of the SARS-CoV-2 genome that was published, that were published online. And so we have stuff from China, from Japan, Vietnam, and then we have things from the US. And so there are two things here. Let's see if I can annotate them. Okay. So we have this US case here from 2020. That was one of the first one. This is the USA Washington 2020 case. Okay. If they have a laser pointer. This guy. Okay. And then when they actually found some new stuff, it was here. Why does this matter? They're on the same branch of the phylogenetic tree, which means they're related. This means that this US case over here, there's probably some introduction from overseas, but this US case here was not. And because this branch was so much longer, it meant that it had changed. The virus had evolved between here and here. So why was this concerning? Well, it meant that actually not only was SARS-CoV-2 here, but that it was actually evolving. Let's see if I can get out of this. Clear. And done. Good. So, oh no, I hope that doesn't stay there forever. Okay, and so what this actually suggested was that there has been cryptic, which meant undetected transmission in the state of Washington for the past 6 weeks. Tableau shut down its offices on March 6th, a week after this. I was in California at the time. I came back home. By the time I came back home, everything was shut down. Although there was a larger stuff and policies in place here, these studies and the discovery of cryptic transmission, as well as communicating it through visualization, made a really big difference in the policies that we then enacted. Throughout the pandemic, we've never had our hospitals in Seattle basically overflow or become overwhelmed like many places in the world had, despite having some of the first deaths and some of the first cases of COVID in the US. And so the Next Strain tool is one that they've actually gone out and developed a lot further. They've been bringing in a lot of data over time. Actually SARS-CoV-2 has had, I think, more than 1 million genomes sequenced. It's a really pertinent and challenging visualization problem since we've never actually had so much data on one virus over time. And Next Strain, I think, is the forefront in actually trying to sequence this stuff and keep track of it. And they're not just doing COVID data, they're actually taking a look at, there we go. They're actually taking a look at a whole bunch of data and they cut their teeth on things like Ebola and Zika. Okay, so the very last one before we wrap up, COVID reporting. So this is something that's also been very personal for me. If you've been in your own region or neighborhood or looked at the news or anything like that, there's been a lot of visualizations and a lot of dashboards on COVID-19. And I myself, throughout this pandemic, to try to understand my own risk of going out in the community, have been looking at the way that my healthcare region is actually talking about COVID-19 data and reporting it as COVID-19 dashboards. And so this is an example of something that I look at every day. It's actually a Tableau dashboard. Not all of the dashboards out there are Tableau dashboards. Some are Power BI, some are custom made. But every day I look at it and it helps me understand the dynamics of the viral spread. And there's a lot more information that they have there too. Our phased reopening, our communication about how it's safe to open or not is also pushed through a dashboard that's connected to this one. But of course, there's actually also been a lot of interesting opportunities to mislead through visualization during this pandemic as well. And to think about some of those problems, I want to point you to two really interesting papers that were presented just at the CHI conference last week. So one is this really interesting paper by Crystal about how coronavirus skeptics use visualizations to mislead and promote their messaging. And she did a very interesting analysis of Twitter data and the kinds of charts that they used and how COVID skeptics actually discussed them, often using scientific-based methods to basically promote their false information. Another one was actually looking at COVID-19 in the media, and this particular individual, this was Janice or Yishuan. She actually came up with a framework at the top to try to explain the quality and understand how visualizations were used and produced by the media as well. And her work was much more focused on how different news outlets were reporting COVID-19. She's got a lot of great examples in her paper of actually going through the visualizations and the context of their creation. And there is something here as well for my own work. Tableau has had a COVID-19 data hub. It's actually basically allowing people to visualize this data for themselves. It's something that in my current work, I'm actually exploring and understanding for my own personal, my own goal of trying to understand how people personalize and contextualize a visualization or an outbreak through data on their own terms. Okay, so that was I hope a interesting set of 4 examples of how I think a data visualization can save lives, especially how design is important and matters. And then I've got a couple just the last minute takeaways. I think that there are interesting opportunities in both public health and clinical medicine. A lot of work in visualization and biomedical visualization I find tends to be focused on clinical medicine, but I think the coronavirus outbreak has shown us the importance of actually shifting some of that focus and thinking about some of the problems related to public health as well. While the two areas have similar data and have actually very similar aims, they still work in different ways and at different levels of impact. But visualization matters to them both. And I think there's more understanding in these communities that visualization is important. And with that, thank you so much for your time. And I'm open to take questions. I saw that there's a few in the chat.
So thank you very much. It's a very interesting and great talk. We have a couple of questions from Discord. So maybe I will start from the first one, which is from Ernesto Avila. Could you further explain how you use Bayesian graphical models to discover mutation in cancer?
Yes, but I will be brief, intentionally brief. So basically, at that time, there were not a lot of methods around for how we actually analyze and scan genomes to actually find anomalies relative to some baseline. And so what we were doing is we came up with something called a mixture model, where we were taking a look at the different genotypes and how often we expected them to occur. So in normal people, that's AB, AA, AB, and BB is the genotypes. And so we actually fit a Bayesian mixture model to actually take a look at, how we would classify different regions of the genome according to those different genotypes. One thing that we did in that particular work that extended it is we actually had an expanded genotype space based on something called copy number variations. And so it wasn't just those 3 genotypes that I mentioned, but it's something that could go beyond it. I think today they've moved beyond using things like Bayesian mixture models, although probabilistic methods still play an important role in trying to understand the cancer genomic landscape. I know that's a really high level, but that's, I think, the right level of detail, because there wasn't a specific visualization in that beyond some of the color codings that you saw, and a lot of diagnostic plots as well in the visualization.
Okay. Although we are running out of time, but I have a quick question from Laura Garrison. Maybe you can quickly comment on it. How is it for you working in industry research related to academia? Of your experience in industry research, which has felt most similar to the style of research you did during your PhD?
Yeah, I like doing industry research, although it can be, depending on what you like to do, there's different trade-offs in it. So at Tableau, I'm allowed to do a lot of what I call blue sky research, which is actually just trying to ask an interesting question and kind of go ahead and chase it. And so there is part of my work that is just that. It's kind of not that dissimilar from academic research, with the exception that I don't have to teach, I don't have to supervise students, and I don't have to fight for grants, which is very nice. I can just focus on the research. But usually when you do work in industry as well, there's more of an emphasis and a focus on what you like, how you can contribute back to the product space. I do actually like doing that. Some people that come from academic industry, from academia, do not like doing that. And there are different companies that have different styles that have a stronger imposition on the researcher has to be doing research on things that are literally what the product is. So some of my work actually does involve working with product teams at Tableau as well. And so that research, like, I always try to find a way to make that collaboration so I can get a research product out of it. And I usually communicate with the teams in that way. And there's some projects that you'll do in industry they're not interesting research problems. I have some of those, they're interesting to me, but they're not academic. So I try to balance it between the blue sky, the collaborations that I can have academic contributions to, and then the collaborations that really have no academic contributions to, but that I'm interested in. With respect to my style of my PhD research, because I had already done stuff in industry, I actually think industry influenced how I did my PhD more than the other way around. And so very much, some of that was like timeline focus, what problems I cared about because I knew they were important versus, trying to figure out what problems people cared about. So things like that. There are more questions. I can answer them in the Discord as we move on to the next speaker.
Yeah, thank you very much for a very interesting viewpoint on the topics.